Good Wednesday morning, everyone. Thank you so much for joining us today. I'm Kara Kumari, Assistant Commissioner for Communications and External Affairs. Thank you for joining us once again for office hours. We will have good office hours today. We'll start the way we always do, and I'm going to turn it over to Commissioner in just a second. As always, we do have the chat box for questions, but we will take questions that were pre-submitted first. And we do want to share some information with you as well. So I'm going to turn it over to Commissioner Turner to get us started and discuss some important information regarding IDD integration. Commissioner.
Yeah, good morning, everyone. Thanks, Karen. Again, appreciate you guys finding the time. I know you're busy to join us for the office hours calls, especially today. I think it's important. As Kara alluded to, obviously, messaging has gone out to share with that integration is going to be delayed until September 1st as the new date. That was not an easy decision from the perspective of just something that was randomly done, but obviously there's significant considerations that are taken into that, and most importantly, being our person supported, how does that impact them, but also our friends in the provider network, and making sure that we're creating something that's going to be successful for you and as a small business that has employees and individuals that you support in your community, that we're making sure that everything is a go on your end and comfortable with what that integrations look like. Obviously, we started getting some feedback and conversations that we were having about challenges that might be associated with payment and billing and processing and things like that. And it was enough for all of us to kind of take a collective deep breath to say, okay, what's the right thing to do here? Because we do not want to sacrifice expediency for the sake of accuracy. So the right thing to do is to wait a little bit and make sure that everyone is comfortable in what that's going to look like on the September 1st launch date for integration, and continue to work very closely with the MCOs, with TennCare, with you as providers, and with folks inside the DIDD network around what that integration is going to look like, and make sure that we get it right. So obviously you need to know that we're hearing you. We're working very closely with our partners in the network and those that are involved in this to continue to make sure that we are going to do this the right way, and that's to create the type of environment and the type of integrated system for person supported that's going to continue to drive other states to continue to follow Tennessee's lead in how we're supporting folks. So that is the big news for today. Obviously, we'll be happy to try to answer any questions we can around that. If there are answers related that we can't answer, obviously we'll treat it as we do other questions and make sure that we just take a time out and go do some research for you and get something back to you. But I'm still excited about where we are, where we're headed. And I firmly believe it's the right thing to do, and we've got the right partners with you guys involved in not only the decision making but the delivery of services. And I couldn't be more grateful for what you're doing and for your transparency and being honest with us about some of the challenges that you see, because we can't answer questions or we can't address problems that we're not aware of. So continue to keep us updated on things that are happening. Share with us the good things that you're seeing and some of the success stories that are happening in your network, because we're excited about that. We're ready to get back on the road and start visiting you again and start seeing some of the folks that we support in the environment that they are creating for themselves in a job and a community and all of those things that are really exciting for us. So when there's more to come on that, we'll keep you posted. But as of now, that's going to be delayed about 60 days. And we'll continue to make sure that we keep that target in front of us, and we'll aim to have any new information that's relevant around that to you as quick as we can. Thanks, Kara.
Okay, so thank you very much, Commissioner, for providing us with that news. We did get some questions that were related about the 7/1 integration date. We're still going to go through those questions because obviously any of the questions would now be 9/1. So we'll still go through those questions, and we understand that this might bring up some other questions as well. So we hopefully will have time to go through some of those questions in the chat box as well. So we're going to start on the questions that were pre-submitted. First of all, as we roll out our startup plan for people supported to increase their time in the community, we need some clarification on how homebound services can continue to be used and billed. If a person supported wants to go out for less than 2 hours each day, are we permitted to bill homebound services for 6 hours for each of those days? I'm going to turn this one over to Jordan, and he will address it.
Yeah, thanks. Good morning, everybody. So it's a good question. The short answer to the question is yes. So throughout the duration of the homebound, the extended homebound period, and I do think it's important to note right now that through the appendix, the approved Appendix K amendment, we have the ability to continue to extend homebound services to everyone receiving a day service throughout the duration of the pandemic, and in fact, up until 6 months post-pandemic. That doesn't mean that we will continue to extend availability of homebound services to everyone. Obviously, we need to consistently balance the level of threat, the individual concern or security of each person engaging in community services, with the need to make sure that people don't fall into a reclusive lifestyle, especially with all the gains that we had made in the last several years pre-pandemic to people integrating in a meaningful way. And we were seeing the results of that play themselves into pre-employment services, higher rates of employment. So there really is a balance that we need to continue to kind of organically observe. As the conditions of the pandemic change, then we can begin to have those conversations with the provider community. As it applies directly to homebound services, the short and fast rule is that, we've heard from some providers, really ISCs more than providers, that there has been instances where people were dissuaded, I won't say not allowed, but dissuaded from going into the community for periods shorter than 2 hours, because that would then somehow negate the provider's ability to bill for homebound services. So a couple of things with that. First and foremost, no one should ever be making the decision as to how they integrate into the community or what services they receive other than the person supported, and that's a given. But people can engage in community integrated activities for periods less than 2 hours and still bill homebound services. Obviously, if someone engages in 2 hours total, and again, that doesn't need to be consecutive, just 2 hours total in a 24-hour period, then the expectation would be that the provider agency would bill the applicable day service, whether that be community participation or other, and then bill wraparound services, which again are funded at the exact same rate, I believe, as homebound services. So there's no billing advantage to billing homebound over an integrated service option. So if someone was in the community for 7 units, so an hour and 45 minutes, then return to the home, homebound would still be an open and available billing option for the provider and for that person supported. Kara?
Okay, and then because we've just got a quick follow-up question, what is the extended homebound date? Has the current date been reviewed and extended? If you just want to reiterate kind of where we are on that, and then we can move on.
Yeah, so we are right now approved through the 30th of June, and like we've done throughout the duration of the pandemic, as we get closer to that date, we'll start to make decisions relative to any extension or hopefully for everybody at that point, the vaccine has produced what has continued to produce what it's producing now, which is much lower rates of infection, much lower rates of hospitalization, and we can think about how we begin to help people reintegrate, how we begin to educate people to the safety of doing so. So right now, we're extended through the 30th of June, and obviously as we approach, we'll communicate about what we're going to do going forward.
Thank you very much, Jordan. Okay, our next question, and this is going to go to Dr. Davis, and Commissioner Turner might want to add something as well. Do you have any statistics on the percentage of DSPs, both within consumer direction and provider agency staff, that have gotten vaccinated, and what incentives are being taken to get these workers vaccinated? I'm going to turn this over first to Dr. Davis.
Thanks, Kara. I actually do not have a lot of information about exactly what percentage of people have been vaccinated at this point, percentage of staff have been vaccinated. We did have early on some information when we registered people that about 45% of those who registered were people who planned to take the vaccine. That doesn't really apply to how many ultimately got the vaccine, I don't think. So I do not have information about how many did that. Now, I'd be interested in the information that anyone can share that would help people understand more about the vaccine, but I do see it as a matter of personal choice for staff to do that. So we want to make sure whatever we present is even-handed. I do want to point out a couple of things, Kara, if I could, for just a moment. And Jordan referenced the effect of vaccinations on our community. And I have a little bit of information that I've put together that I think might be useful to people and interesting to people as well. Just give me a second to pull that up so I can review it. Now, a couple things I want to say about this. One is that our first date of IDD vaccination, so we were in phase 1A1, and all of the information I'm going to give you right now is pertaining to person supported, not to staff. But our date of first IDD vaccinations was December 22nd of 2020. So that meant that the first date that anybody could have been fully vaccinated with the Pfizer vaccine would have been January 25th of 2021. The first date that anybody could have been fully vaccinated with the Moderna vaccine was February the 2nd of 2021. I have done a lot of analysis of the hospitalization and death data. The last death that we had reported to us was on April the 1st. I don't think that actually ended up being the date that the person died, but that the date it was reported to us because the person was in a hospital arranged by a parent. And so under that circumstance, we were not able to get the definitive information about the exact date of death, but that person got sick on January 31st. So we had that first reported to us a positive test result on January 31st, which was unfortunately before I believe that person had the opportunity to be vaccinated, and that person was not vaccinated. We had no other deaths after January 31st. Through February and March. So that is a fairly remarkable outcome in February and March, given that we had been at a rate that was about 3 to 4 times as many as the typical population. I'll share that information with you in just a second. But the average age of people who died in our system from COVID-19 was 61.51. The range was from 21 to 83 years of age. The average age of DIDD persons hospitalized was 54.4, range from 15 all the way up to 92. We had a 92-year-old who survived COVID-19 through this. That's remarkable. And so looking at the rate of death, we had been running, pretty much had gotten to right around a 3 times the typical population rate of death in our population. We had 17 deaths in January, so that was a really rough month. But in February, 0 deaths. In March, 0 deaths. A substantial decrease even while the typical population was continuing to have deaths during that period. Also, as it relates to hospitalizations, I probably should have said this first, but we had run as high as 5.29 times as many hospitalizations as the typical population. During February, we had 4 hospitalizations, or let me go back to January. During January, we had 31 hospitalizations. January was by far our worst month. And in February, we had 4 hospitalizations. In March, we had 6 hospitalizations. And those rates were slightly higher than what the typical population was, but not nearly to the degree that it had been before that. So you can't necessarily, from a statistical perspective, attribute all of that to our getting vaccines in place, but it does paint a pretty good picture for what the vaccination process was able to accomplish among those who are reporting their information to DIDD. So I just wanted to take just a moment, Kara, to share a little bit of that information I think is useful to people. And as Jordan said, as we're considering where we're going to go from here, that this data is pretty encouraging. I do want to not have people relax too much, because I think you can start to re-engage more, but you need to continue following some of the guidance that's been given related to wearing masks, related to distancing, because even with the vaccination, people are still able to pass the virus along, and so we want to be careful about those interactions for those people who have not been vaccinated at this point, and to prevent the spread. So, Kara, that's a little bit of a summary from the clinical perspective.
Thank you very much, Dr. Davis. And yes, I think that we're all very enthusiastic about some of the things that we've seen, and some of the promising data we've seen. Lisa, I see that you said in the chat that is there any is this info getting out to the media? We're still collecting the information. We actually did send out a press release, I guess about a month ago, discussing the extremely steep drop in COVID infections in both persons supported and staff that we were experiencing since December. So we have been doing what we can to show some of the progress that we've made. Okay, I'm going to move on in our pre-submitted questions. I am emailing to inquire about the ISP PCSP template. Will those in the 1915 waiver need to be converted over to the new template effective July 1 or now September 1? Or will the ISCs be expected to utilize two separate templates? I'm going to turn this one over to Courtney Kelly, our Assistant Commissioner of Accreditation and Person-Centered Practice. Courtney.
Good morning. So we're working to have everyone use the same template. So when we go live, the date has been pushed back, but when we go live, everyone will use the same template, which is the new revised person-centered support plan.
Excellent. Thank you very much, Courtney. Next question is going back to Jordan. Have the 1915C amendments that were posted on February 22nd been submitted to CMS? Jordan, there's a short answer here, but I'll turn it over to you.
Yep, that's the answer to that question is yes. They went later last week. I believe it was Thursday, but they have been submitted.
All right. Thank you very much, Jordan. Okay, the next question goes back to Courtney. Will the ISCAs be responsible for monitoring and implementing the entire ISP PCSP plan or portion of the plan? Who is responsible for what? Facilitating meetings, etc. Courtney, back to you.
Okay, so yes, nothing's changing around roles and responsibility of ISCs once we move over to implementation. Everything that ISCs do now in terms of monitoring the plan, writing the plan, facilitating the meetings, for those people who are supported in the 1915C waivers, that will continue. The same thing you're doing today, you will continue in the new integrated system. Yeah, making sure I didn't miss any piece of that.
All right. Well, you'll come back in just a second. So
okay.
We're back over to Jordan. So if you forgot, you'll have time to answer again. Self-directed waiver question. How will this affect dental, and where does dental funding come from? Going to turn this one over to Jordan.
Yeah, it's a really good question. So dental funding will remain the same. So the allotment on an annual basis, and then the allotment allowable in a multi-year format won't change, obviously, with the amendment. We are changing the provider that reviews the treatment plans for dental. So the routing of that, we will communicate exact routing specifications. They're still in the process of being developed, and at the point at which we've got those, to be honest, they're probably going to mimic the ECF dental billing claims process, but until we finalize that, I don't want to speak definitively on that. There are two things that are true. The first of which is the department will continue to calculate maximum benefit allowance, so MBA on everybody. Will continue to bounce that up against the annual and then the multi-year limit. And then Delta Dental will be reviewing the adequacy or the validity of those claims. And so we will delineate that process very clearly and communicate it as soon as it's finished and well in advance of the integration implementation date. Thanks, Kara.
Thanks a lot, Jordan. Okay, back to Courtney. ISP, PCSP question, how are goals tied to services?
So goals are tied to services based on what it is that the person is trying to achieve. So when you start working with the person, you look to assess to see what the needs are for the person and what the goals are for the person. What is it that they're trying to accomplish? So for example, if you have someone who has mobility issues and they want to be more independent in their home, they want to do more things, increasing their mobility, be more independent in their homes. Let's say they want to cook, learn how to cook. Then you look at the services that support them to do those things. So whether that's a therapy service, just depends on what it is based on what the goals that the goal is that the person wants to accomplish. And so you build those services around that. So that's how you tie those services into the outcomes and actions. That's what leads to the accomplishment of outcomes and actions for people supported.
Okay. Next question. Will there be new tools to help assist with creating an ISP PCSP?
That's
Yeah, Courtney, the rest of the question is kind of examples, so I'll let you
okay.
answer that one.
Okay, new tools to help assist grading. So that's a good question. So currently what we have is the ISP guidance document, which can be found on our website. And it pretty much provides a general overview of all of the things that the ISC needs when building and creating an ISP. Things that you look at, documents that's collected and analyzed, so on and so forth. So for the new person-centered support plan, we are still working on that and working through what's needed, what it's going to look like, how is it going to work. So we're kind of early in the game right now, but there will be more information soon once we get it all sorted out. But those are conversations that we're having right now around what type of supporting documents in terms of training will there be for the person-centered support plan. So we're working on it.
And one more question for you. Who or what determines the visits, in person or virtual, come July 1?
So, well, now the July 1 date has changed, but right now we're following the guidance of the Appendix K amendment. That's where we are right now. So we will continue to do that. But behind the scenes, we're working and having discussions around, resuming face-to-face visits when it's safe, those type of things. So we will provide a directive when the time comes for folks to start getting back out there and, holding those face-to-face visits. But right now we're following the guidance of Appendix K, and we will continue to do so until we get further direction.
And then, Courtney, there is a question in chat that's related to all of this, so I'm going to ask you that one while I've still got you here. Currently in ECF, the agency writes the PCSP. Will the ISC be writing those and sending them to the agency, or will this stay the same?
Oh, for ECF, it will stay the same. The ISCs will be writing the plans for the people who receive services in the 1915C waivers, and the MCOs will continue to write the plan for those who are receiving services and supports in ECF.
And then with ECF, it is highly common for MCOs to exclude providers from all meetings they schedule. Will this occur with integration for the 1915 and self-determination waiver?
So
Courtney?
that's something that we are discussing. We haven't made a final decision yet, but there are discussions occurring right now around that. So still early yet, but we will share more information once a final decision is made.
Okay, so I think the only thing that I see as far as, and if you have other questions in chat, I'm kind of looking because some of the questions were follow-up questions in chat. So the question that has come to us is, can providers bill HB if people want to go out for shorter periods? Just to correct some misinformation, and the answer is yes. Jordan, do you have anything else you want to add about that?
No, that's exactly right. I think that's the important point that we want to make is that people can bill. You can't bill homebound services if you bill another day service. And if someone is out in the community for more than 2 hours, then obviously the provider agency would want to bill the other applicable day service. It's reimbursed at a higher rate. It's the preferred outcome for people to be integrated. So what we're really trying to get to is that people don't need to be, nor should they ever be, kept home. And just saying that out loud kind of gives, I'm sure, all of us the chills, because provider agencies are afraid that it will compromise their ability to bill homebound services. Yes, homebound services need to be billed in a 6-hour block. Anything less than 24 units won't be accepted as billing, and that's been the case since the onset, so nothing has changed there. But also it is true that people can be out in the community, and it doesn't compromise your ability to bill homebound services during this extended Appendix K approval period, as long as you're not billing another day service. And again, if they're out in the community for longer than 2 hours, you're not going to bill homebound anyway. You're going to bill community participation or employment. So yes is the answer, unequivocally.
Excellent. My next question is, where do we find Appendix K, and does this information apply to TEIS? So Appendix K only applies to the HCBS waivers, and it does not apply to TEIS as far as services go. But that Appendix K information can be found on DIDD's COVID page, which is still active, and we do have those links there. Okay, that's all I see. So I am going to say that we've had a very good office hours. I think it was a very varied office hours, and we hope that you all are feeling good this Wednesday afternoon. So Wednesday afternoon, I have apparently been up for a long time. Anyway, I will turn it over to Commissioner Turner to see us on out, and we'll be here same time, same place next week. Commissioner.
Yeah, thanks, Kara. And again, thank you for your questions that you guys have submitted. Thank you for your patience on some of the questions that we might not have answers to, allowing us some time to be able to find those answers for you. And like Kara said, we'll do this again next week. So please continue to share questions if you've got, feedback, any information that you think is relevant and important for us to know. We need to hear about it. So I appreciate you guys and your time today. Look forward to talking with you next week, and I'll kick it back to Kara. Thanks, everyone.
Okay, like I mentioned, we will be here next Wednesday, same time, same place. Look forward to having this time with you all. And like I said, thank you to those who pre-submitted questions. We are always here and hopefully able to answer what y'all have on your mind. Talk to you later. Bye.